So again, good morning and welcome to the second Learning in Action Network webinar for the Million Hearts Project, or the Cardiac Task, through HealthInsight. So today we're talking about the future of payment reform with specific focus on PQRS, meaningful use, and the value-based modifier, with a little mention about patient-centered medical homes. My name is Rebecca Valley, and I'm a Facilitation and Improvement Specialist with the Oregon Healthcare Quality Corporation, an organization that's working with HealthInsight and Acumentra Health for this Million Hearts cardiac work. My role for this webinar will simply be to facilitate and moderate, because we have a fantastic panel of experts who are going to share their knowledge with you. But first, a brief introduction to HealthInsight for those who aren't yet as familiar. HealthInsight is the Quality Innovation Network Quality Improvement Organization, or QIO, serving Nevada, New Mexico, Oregon, and Utah. There are 14 QIOs in the U.S. that bring Medicare beneficiaries, providers, and communities together in data-driven initiatives that work to increase patient safety, make communities healthier, to better coordinate post-hospital care, and improve clinical quality. The QIO work is grounded in principles aligning with the goals for the Centers for Medicare and Medicaid Services, CMS, quality strategy, which are to eliminate disparities, strengthen infrastructure and data systems, enable innovation, and foster learning organizations. Along with the 13 other regional QIOs, HealthInsight is leading healthcare quality improvement initiatives, including this Million Hearts initiative for the Medicare program for a 5-year period from 2014 to 2019. Acumentra Health is HealthInsight's Oregon affiliate in this work. And this webinar is part of an ongoing Learning in Action Network series under the CMS project on cardiac health specifically. Our objectives for this webinar today are to define key concepts under PQRS, meaningful use, the value-based modifier, and medical homes that are relevant to Million Hearts Initiative and some of the other tasks. We'll learn about the related types of technical assistance offered by HealthInsight and Acumentra Health. And then we want to spend a bulk of our time sharing barriers faced, success stories, and some of the preferences for ongoing educational opportunities regarding these topics. And that'll come out of some of the questions that you asked. So to accomplish these objectives, we're going to have one of our panelists provide a short 10-minute high-level overview of the key concepts for discussion, as well as their respective changes and how those changes may affect your practice. We'll then have topics that we aren't, the remainder of the presentation to use for Q&A with our knowledge experts, and any topics that we aren't able to clarify, or if there are specific concerns that come up over and over, we may use that topic as the basis for a separate webinar in the future. Let's see, did we get any responses on the phone of what people hope to? Let's see. Okay. So we have Tara from the Portland Clinic hoping to find out if there's any new information out there on these topics, interested to hear what other people's questions are. We have Kelly and Eliza from St. Mark's Family Medicine who want to better understand the future payment models and properly position themselves for this to plan looking forward. We have someone who wants to increase their understanding of how we can best align with the future changes. We have Jacqueline from Klamath Tribal Health and Family Services who's wanting to learn more about healthcare services available in Oregon. And then Cassie and Sean from Corvallis Internal Medicine who want to learn how to achieve credit for what they are already doing. Absolutely, that's what we want to help you do. You're doing great work and we just want to make sure you get credit for it. So I hope we're able to answer that, all of those questions. And I know that we are in great hands today with our panel of knowledge experts to answer those questions and to provide some relevant examples for you. So first we have Daniel Chipping from Utah on the line. Daniel is a practice facilitator at HealthInsight in Utah for the northern part of the state. He is currently working as a project manager for the CMS task, focusing on improving the use of health information technology and improving adult immunization rates. Before coming to HealthInsight, Daniel worked for the research department of the Veterans Affairs Hospital and also managed a private family practice physician office. Daniel graduated from the University of Utah David Eckley School of Business with a dual Master's of Business Administration and Master's of Healthcare Administration. Also on the line we have Brooks McClellan. Brooks has been working as a project manager on the HIT team at HealthInsight for the past year and a half. His responsibilities include helping providers implement EHR quality improvement projects and including the EHR incentive program and the cardiac quality monitoring project. He has worked in the healthcare industry since 2003 and has spent much of his career working as a certified cytogenetics technologist in a diagnostic laboratory. Brooks has a bachelor's degree in biology with a minor in chemistry from Utah State University and a dual master's degree in public health and healthcare administration from the University of Utah. And finally, also on the call today is David Smith. David has worked in quality improvement and healthcare technology roles over the past 18 years. He recently helped an EHR company certify their product for ONC certification. Additionally, he worked for HealthInsight for 4 years, performing quality improvement work, leading education and outreach efforts for meaningful use, and working on the next stage interoperability under the National Beacon Grant. He has an MBA from Westminster College and a BA from Brigham Young University. So welcome to all of our panelists. I'm very excited to turn it over in just a second. But first, I just want to explain a few things about the technology, just in case you have questions throughout. Since there are so many of you on the line, everyone is on a global mute, and you will remain on a global mute unless we individually unmute you. We do have time set aside to address your questions, plenty of time. And what you can do is either type your questions into the questions pane as you did in the beginning, or when it comes time to question and answer, if you look next to your name on the right side panel box, there's a little hand icon. You can click that to raise your hand, and we can unmute you to verbally express your question. And just to let you know, we will provide the slides and a recording of this presentation after the webinar. Also, if this is your lunchtime, please feel free to eat. So without further ado, I'll hand things over to Daniel. Daniel, take it away.
Thank you very much, Becca. I don't think the eating offer includes me and Brooks and Dave, but but the rest of you enjoy your lunch while we take a few minutes and present. We're glad to be here today, and we appreciate all of you taking the time to join us. I'm going to really quickly try to go through what's been happening in legislation and give an overview explanation of the things that have occurred and help form a picture in your minds that let you know where payment reform is going, what's happening with meaningful use and quality reporting, and hearing all about ACOs and kind of where does it fit with your practice and what do you need to be thinking about. So we will make it quick so that we've got plenty of time for Q&A. So the first thing I wanted to point out is this big thing called MACRA, Legislative Standardized Growth Rate. The standardized growth rate was legislation that had occurred years and years back that basically every year providers were going more and more into the negative for potential reimbursement loss. And each year Congress had to extend a bill that prevented that disincentive or that discount on their reimbursement. So as of this year in 2015, providers were close to losing 20% of their Medicare reimbursement if Congress did not either again or fix and discontinue the standardized growth rate. So what we saw happen is Congress, in a bipartisan legislation, signed into law on April 16th the Medicare and CHIPRA Reauthorization Act. So the acronym being MACRA. So what MACRA has done is taken the current programs that we've all been dealing with, meaningful use, PQRS, the Physician Quality Reporting System, the value-based modifier, And it's taken all of these and changed them from being disparate, distinct programs with different groups overseeing each, and put them all under one umbrella so that they can all be modified to build and support one another, to eliminate duplication, and to be written so that they're promoting the goals of CMS to reduce costs, to improve health, and improve healthcare delivery. So MACRA has basically set it up so that practices can choose between two different models. The left side of the slide is the merit-based incentive payment system. So that's the first model that a practice can choose to follow. And the right column of the slide shows the alternative payment models. And that is the other option that a practice can get into for the coming payment reform efforts. So most of our slides today are going to be focused on the merit-based incentive payment system, but I did want to point out to you on the alternative payment models. The Accountable Care Organization, we do have a handout that's in the right side on the control panel. If you look in the handout section, there's a toolkit that's been provided and built by the Brookings Institute and some great people who contributed to that. It is a 62-page document outlining what you need to be successful in the Accountable Care Organization model. And really a great resource, and don't let the size of the document scare you. You get most of what you really need in the first 4 or 5 pages. They do a great job as an executive summary of outlining the key areas that practices need who are either signed up already in an ACO or who are thinking about participating in an ACO. So make sure and download that handout and definitely read through it and use that. Some great material in there. The other piece of the alternative payment model that I've seen mentioned, and the reason I have question marks next to it, is because MACRA has just been introduced to the industry, and CMS, or the Centers for Medicare and Medicaid Services, has asked for input from everybody. So they're going to be gathering comments and suggestions, and all we have right now is a basic outline or a framework of what they want the program to look like, but they need input from everybody else. So some of the things that I've seen published include PCMH, or patient-centered medical homes, and I know Oregon calls it something different, and let me just look at that up really quick. I apologize, I should have had it on this slide. The patient-centered primary care home in Oregon, just to make sure we're all on the same page. I've seen in some documents that that's included in the alternative payment model, and I've seen others that only talk about accountable care organizations. So I think research and find out more as MACRA is developed. So the rest of the slideshow is going to focus on each of the 4 areas that are part of the merit-based incentive payment system. So before I go into each one specifically, I just want to point out that the composite score that a practice will receive in the MIPS program will be based on your performance in each of these 4 categories. EHR meaningful use will have a 25% weight, quality will have a 30% weight, and that quality will be through the PQRS, or similar to what we know as PQRS. The the resource use, that's driving down cost, and that's what we know through the value-based Modifier program right now. That has a 30% weight into the overall score. And the clinical practice, oops, I apologize, I wrote the wrong word. It's clinical practice improvement, not clinical process improvement. Clinical practice improvement will have a 15% weight on the overall aggregate score. And the reason I put PCMH again next to that is basically Medicare is saying that PCMH elements will be what makes up clinical practice improvement. So we'll go into each one of these a little bit. I think everybody's aware that meaningful use is very useful, and it's not useless. We do hear a little bit about people questioning the usefulness of it, and so we thought a fun little graphic with a misspelling would be appropriate just to add some flavor to the slide deck. But meaningful use has changed very much in the last year, well, in the last quarter, really. We had a delayed publication telling us that of all the changes that have occurred. So this is just kind of a brief overview to help you know. Oh, and I'm going to start with this quick poll. So go ahead and select which one of these your practice was involved with in 2015. And then we will have, Becca will share the results of the poll with us. So which meaningful use stage are you reporting in 2015 is the question.
Great. We had some good responses over here, Daniel. So it looks like about 25% of folks on the call today were reporting at stage 1, about 55% at stage 2, 0% at stage 3, 10% weren't sure, and then another 10% said that their practice is not currently participating in meaningful use. Thank you, everyone, for participating.
Great. Yeah, thank you for the results. So it's really interesting to me that 10% are unsure and 10% don't report meaningful use. And I want to address those two groups really quickly. With the changes that have occurred, I work with 40 or 50 practices in the northern part of the state of Utah mostly, and a lot of my practices have kind of stepped back and said meaningful use is too overwhelming and it's a big challenge for us and we don't want to report anymore. And that happened sometime last year and early this year. And a number of my practices now, with the new rule that's been released, it's actually simplified. We've gone down from 17 core measures and 6 menu measures in stage 2 down to only having 10 measures that we need to report on. A lot of the redundant or duplicative measures that didn't add value to the practice have been removed. And so the focus is on 10 measures that will make meaningful use much more meaningful to providers and to patients. And I have had a lot of practices coming back and saying, yes, we do want to participate now. It's getting more in line with where it should be. For the 10% who are unsure of which stage they're in and how to report, that's kind of why we're here today, and just in general that Acumentra and HealthInsight can help support you and help you understand where you're at in the process and where you need to be focusing. But the overview for today, just wanted to highlight that 2015, for anybody reporting stage 1 or stage 2, the measures are the same, but for stage 1 reporters for the first time, you get some exclusions that if the original stage 1 measures did not align with the stage 2 as it's written now, then you get some exclusions from reporting on those measures, which helps ease the burden as well. 2016 and 17, everybody will be reporting on stage 2 except for new providers who are attesting for the first time. They will continue. They will also start with stage 1 for 90 days. And in 2018, stage 3 proposed, as it's proposed, will be implemented. Providers will be starting or continuing meaningful use reporting on stage 3. And just a quick reminder that there is no more incentive for new providers who begin reporting in 2015 or beyond. There is a remaining incentive for providers who are in the midst of their 6 years of reporting who started early, and most of meaningful use is geared towards avoiding a disincentive. And the next slide is PQRS. So PQRS, just a quick, oops, I pushed the button too many times, sorry about that. PQRS is just about reporting quality measures, and many of you will know, and maybe this is new for you, there's 2 questions that we need to answer for PQRS. One is how do you report, and the other is what do you report. So quickly, the program allows 5 different methods for reporting. So we're going to go ahead and have you take another poll and tell us which way are you reporting for PQRS. Now understand that the second option, which says through our EHR, that's either the EHR helping you report and creating a file that you upload, or the EHR uploading the file on your behalf to CMS. So we'll go ahead and take a minute and let you guys all answer that question, and then wait for the results from Rebecca.
Okay, thank you again for submitting your poll answers. We've got over here 6% of folks on the call that are submitting through their claims, 56% through their EHR, 25% through a registry, 6% aren't sure, and 6% are currently not reporting PQRS.
Okay, wonderful. Thank you so much. Again, really telling results, and I want to highlight a couple things. The claims method of reporting is more and more becoming pushed against by CMS, and they're trying to eliminate it as an option. So the 6% of you who are reporting via claims, we recommend strongly that you begin looking at another option or method for reporting. The 50% of you, 51 I think percent who are using the EHR, that's where most of the claims reporting is being driven to. And so any certified EHR that was certified in 2014 to meet meaningful use, also certified to be able to report PQRS through either the method where they help you to submit the data or where they submit for you. So the 6% of you who are reporting claims, if you have a certified EHR, make sure to talk to your vendor and ask them which way they will help you report PQRS, and start looking at how to do that with them. The other options for registry, there are a number of registry vendors throughout the country who will help kind of go in under the hood and help you find the quality data to report for you on behalf. And the idea for registry is it is somebody else who's assisting, so there is a cost associated with it, and you can expect between $300 and $400 per provider is kind of the competitive range of what the costs are for that. And GPRO has mostly been, that stands for group reporting, and that's mostly been larger practices who do that, but the group reporting has been expanded to include anybody with 2 or more providers has access to be able to report via the group method. The second question is, what do you report? And you need to be reporting 9 quality measures across 3 domains, or what I like to call families of measures. And there are 6 available domains, and so you need to be reporting measures from at least 3 of them. Again, PQRS is reporting in order to avoid a disincentive, so to avoid a penalty on your Medicare reimbursement dollars. And again, HealthInsight and Acumentra Health, any of us who work out of these offices will be able to help you understand PQRS more fully. I do want to say that for the group who says they are not reporting PQRS, you are already receiving a penalty on your Medicare reimbursements, and that penalty and that lack of reporting will affect your value modifier score. So we're going to talk about the value-based modifier soon. I just wanted to point out this slide has a couple resources for you. We have the CMS final rule for the physician fee schedule, which is also a part of the MACRA. We've got who is an eligible provider for reporting PQRS. We also have one other option which I didn't mention, but under registry vendors there's a group called a qualified clinical data registry vendor, and it's slightly different, and I think what it does is allow us to report some additional measures that are not available through other registry reporting. And just to highlight, there is movement in the measures all the time. So I'll just specify on QCDR again, the way that CMS has it worded says, the data submitted to CMS via a QCDR covers quality measures across multiple payers and is not limited to Medicare beneficiaries. Okay, and it's different in that it is not limited to measures within PQRS. A QCDR may submit measures from one or more of other categories or following categories. So we've got the CAPS, the patient satisfaction surveys. We've got NQF, the National Quality Forum, and PQRS measures that are all options for reporting through a QCDR. And the last thing I wanted to mention is that PQRS is always moving. Measures are always being added and deleted or updated. So make sure you understand the measure specifications and what the measure is asking for when you're looking at reporting your quality measures. So as I mentioned, PQRS feeds into this value-based modifier score, which currently as it stands, if you're not reporting PQRS, you get a 0 for your quality. And so when you get a value modifier score, you're automatically in the bottom 25% because you have a low quality score and it doesn't, and your cost, well, depending where they are, you will have a disincentive based on the value modifier. So if you're a practice that's not reporting meaningful use or PQRS, and then you're automatically getting negative incentives for both of those, then you're also getting a disincentive for the value modifier. You can be losing up to 10% of your Medicare reimbursement on these three programs. And the top 25% on the value modifier currently as it stands are receiving incentives that are the sum of the disincentive for the bottom 25%. So it's hard to say that it's an additional 1 or 2% because they're basically splitting the pie from all those who are losing money in the bottom 25%. So just a couple points to show on the value modifier. Your quality and cost scores are adjusted for complexity of your patients as well as your geographic location. We do recommend that you access your feedback report. It's called the Quality Resource Use Report. And you get to that by logging into your what is now an EIDM account. It used to be the IACS account. So if you had an IACS account, automatically transition to this.
I apologize, folks. It seems that we lost Daniel's audio for a second, but while we're waiting for him to log back on, we'd be happy if you could just quickly respond to the poll. So have you seen your QRUR feedback report?
Your QRUR feedback report. And while you're answering, I'll continue. Sorry, go ahead. Okay, a little bit there, sorry about that. So I think we'll get the results from Rebecca and then we'll go, I'll talk a little bit more about the tiering.
Okay, great. So we've got about 12% of folks on the call who said yes, they have seen a QRUR report. About 53% said no, they have not. 29% said they're not really sure or what is a QRUR feedback report, and 6% had an other response.
Okay, so yeah, I'll just use that to highlight the idea that logging in and creating your EIDM account is actually a significant challenge. CMS has about a 40-page document to help you log in. And it's a little bit of an onerous and overwhelming process, but it is required. Once you have your EIDM account, then you can click a button that will allow you to see the report. And we definitely recommend that you want to look at your quality resource use report so that you can find out where you're at and what areas you need to do to make improvements in so that you can be in the top 25% I just did want to mention quickly that solo practices only have an upward value modifier adjustment, and they don't have a negative. Groups between 2 and 9 practitioners will have the possibility of losing up to 2% or gaining a 2 times factor in that top 25%. And if for eligible providers or groups that have 10 or more providers, they will qualify for losing up to 4% of their reimbursement or receiving up to a 4 times factor if they're in the top 25%. Finally, the medical home, or again, as mentioned earlier, the patient-centered primary care home in Oregon. This is the 4th category that is the clinical practice improvement area. And the idea is that it's medical home principles that you'll be judged and ranked on, and they include patient-centeredness, comprehensive care, care coordination, access for patients, quality and safety, and team-based care, to name a few. And what it means is that you will be given a score or judged on your performance in these categories. So if you haven't thought about performing or gaining a medical home recognition through the NCQA or some other body, then you may consider that now, because if you do have, for example, NCQA level 3 recognition, then you automatically get 100% of the score possible in the clinical practice improvement category. And with that, I just wanted to wrap it up by saying that the MIPS score, where all of these programs have been separate and disparate to this point, each one of them is an all or nothing, so you either report all 9 measures or you don't, and you either get the incentive or you get the disincentive. And the same with meaningful use, you meet all the measures at 100% or above the threshold, or else you don't qualify. Under the MIPS, it's a little bit different. You'll actually have that aggregate score where all 4 of these areas are combined, and your score will be, it'll be a sliding scale. So you can get 90% on meaningful use and maybe 10% on your quality and 50% on your cost. So then you'll get an overall score at the very end that accounts for partial performance in each category. And I just wanted to highlight and say that we do know that by the year, I think 2022, providers will be able to receive up to a 10% or 9% for sure, and a potential of negative 9%. And I have seen one source that says it can get as high as 20% for the high performers, but I'm a little bit unsure about that, and I'm looking into it to find more information. So with that, I just want to offer again that HealthInsight and Acumentra Health are both available to help you guys understand, to even access your UR reports, to know where you are as far as meaningful use and being able to report in any of these areas, to understand the details of the programs. And we'd love to also help you provide feedback to CMS to make the programs more meaningful and helpful to you and line up more closely with what you're doing in your practice. And I think with that, we have our slides, our information available so that you can reach out to us if you need and have any questions further. And I think this is the part where we go to Q&A, right, Rebecca?
Absolutely. This is the time for Q&A. Thank you so much, Danielle. I think you packed a lot of information into a short amount of time, so I'm sure there are some questions. We have a couple that have come through. So just a reminder, you can submit your questions in the question pane, or you can raise your hand next to your name and we can unmute you. There is a little bit of echo feedback, so we'll just ask that you mute your speakers if you're going to call in. And if you have a question for a specific person, you can address it to them in your response here. So our first question is from Steve Kinzer, who asks, is PQRS required for hospital emergency department physicians? Some of these physicians also work in their own clinic that are not hospital-owned or run, and others work in a hospital-owned clinic since July 1st of 2015. Will the hospital see disincentives if these physicians are not reporting?
So I missed the first part of that question. Dave, are you able to answer it, or should we have you repeat the question, Rebecca?
I think this is a good one for Brooks, actually. I'm going to put you on the spot, Brooks.
It's about emergency department physicians.
I think I could answer briefly. If the emergency department physician is practicing in their own practice as a primary care doctor, for example, and they're seeing Medicare patients, then I would think that they would need to report PQRS to avoid any penalties with regard to their Medicare Part B reimbursement. Brooks, do you concur? Is that accurate?
That is correct. Whether each provider is compliant with PQRS reporting and the meaningful use, it follows their NPI. So if they're billing under that NPI, then they'll have the negative reimbursement associated with that NPI. But if they're billed through another doctor, or if they're, it depends on how they're billing with their NPI.
And I'll just add that it, again, like Dave mentioned, it is on Medicare Part B claims, the reimbursement of those claims only. So there are some hospitals whose providers do bill some of their Medicare or some of their visits through Medicare Part B, and it gets reimbursed, and it does affect the hospital. So you need to look into that and see if any of your providers are billing Part B claims.
Yeah, and a lot of your rural clinics will have a different type of Medicare. I think it's Part A that they're reporting or something like that, and so they don't have to report the PQRS or meaningful use.
Yeah. Does that answer the question?
I think so. And we also had a comment from one of the state leads who said, please follow up with your state lead or your project lead on specific questions if we aren't able to fully answer your questions today. And Daniel and Brock, can I ask that you said, oh, you're on the computer, never mind. The next question is, how will critical access hospitals with rural health clinics be affected by the changes? Also from Steve.
I'm sorry, Rebecca, we're losing you just a little bit. If you could try repeating that one more time.
Sure. The question is whether or not critical access hospitals how will critical access hospitals and rural health clinics be affected by these changes?
So again, I think that's a good question that I don't have a full answer for. Definitely, any providers who are reporting Medicare. Okay, go ahead, Dave.
Usually, you're billing Part A through rural health clinic, so I don't believe that it affects the reimbursement, but they've been trying to align Part B with Part A outpatient billing programs, and so I wouldn't say that you're completely off the hook. I would say you want to stay in the know about what might be coming, but I don't understand. My understanding is that it wouldn't affect Part A billing right now.
And I just want to apologize for the audio issues we're experiencing at this point. There's some echo and feedback, and we're going to try and troubleshoot, but until then, please bear with us. We have another question from Eric Weathersby, who wants to clarify that the QR/UR report is in the EIDM account. Is that correct?
Yes, that is correct. You need to have an EIDM account to be able to log in and access your QR/UR report. And that's for either a representative for multiple providers or each provider individually. Generally, the EIDM account, you need to have two logins, a security official and a reporting person, and then you're able to tie the NPIs, I think, to the providers who you want to view reports and be able to pull up their reports. Or put a tax identification number in, and any provider tied to that tax identification number, you'll be able to see the report for that individual.
Okay, thank you. The next question is, with the new meaningful use update that came out in October of 2015, does that mean that if we are reporting for the second portion of stage 2, do we only have to report for the 10 objectives, or are we still reporting for the original 18 objectives? That question comes from Deanna Wood.
So everybody in 2015 is reporting on the new 10 measures for the modified stage 2. So you would just report on the 10 measures. The only people who report something different than that are providers who are attesting for stage 1, and again, they report on the 10 measures with a few exclusions, so they don't quite report on all 10. So all of the things that have been eliminated from stage 2 in the changes, they will still show up in your EHR dashboard report, but you can ignore many of them and just focus on the 10 that are required.
Okay, thank you. There's another question we have from Kelly Downland. I'm not sure which state she's calling in from, but her question is, if we are a good PCMH clinic, do you see the need to join an ACO?
That's a really good question, and that's where I had a few question marks on that one slide. There's been suggestions in some of the presentations that I've seen on MACRA that PCMH is almost synonymous with ACO, so it may be counted as an alternative payment model. So that's the question that I'm waiting to find out a little more information on to confirm whether or not you can do an alternative payment model either as an ACO or as a PCMH, and I think they would be independent of each other, so you would not need to do both. However, again, I'm not positive that that is the case. So otherwise, if you did PCMH and you didn't want to do ACO, then your PCMH would satisfy the requirements for the fourth area under the MIPS score, which is the clinical practice improvement, and then you would still need to do PQRS, meaningful use, and your cost reduction or your value modifier pieces of the program. I hope that answers the question, Kelly.
I think so. We didn't get a follow-up. There were a couple of comments that came in about people experiencing some frustration with reporting through PQRS, and I'm just wondering if you have some advice for those folks about how to make it a little bit easier for them and how to make sure that the reporting is accurate and that what they get back from CMS is clean. Do you have advice for that or next steps?
I might be able to add in there.
You have to talk to them maybe on a case-by-case basis. Go ahead, David.
Sure, Brooks. So I've noticed a few people in our state have gotten letters where they felt like they were done with submitting PQRS. I've been doing a little bit more reading, and it seems that when you're submitting PQRS, one thing you don't want to submit is a 0. If you do submit a 0 on one of those 9 measures, that may invalidate the entire PQRS submission process with PQRS. And so if you have measures that are simply turning up nothing and you report them, you want to avoid doing that. So you want to make sure that you have good and accurate data when you submit it. Also, there's another process that you can go through if you feel like there are not enough measures for your specialty. The other area that you want to look into is make sure that if you're using a vendor, that they're reporting effectively for you, and that you have the ability to understand where your quality is at, so that you can see if you're in that upper 25th percentile, because that's kind of the goal. If you want to get more payment from Medicare in the long run, you want to start getting into that upper 25 percentile in terms of performance, so that you can be sitting nicely when it comes for time for Medicare to pay more based on the quality that you're providing.
I think that's great advice, and I again would recommend that folks contact their state leads or their project leads at HealthInsight or Acumentra Health. They are great resources for you to point you in the right direction, to walk you through your specific situation too.
I would also like to add that, if you're having troubles, registry is usually a pretty good option. They can go remote into your EHR, and they can kind of explore different measures a little bit and see which ones you're getting higher percentages on, and also report that for you, and it's not too expensive.
I'll back that up, what Brooks was just mentioning, and just say that a lot of EHRs and clinics that I've worked with, their EHR limits which measures they can report on. So if you're a specialist with a EHR that's primary care focused, and you don't have measures that reflect what you do, then the reg would be the right option. Or if you've got an EHR that for some reason a lot of EHRs have difficulty translating what's happening in the chart into the dashboard report, and so you're getting a lot of zeros, then the reg is a good way to go, because they can access the information in the database and find it and pull it out and plug it into the reports and submit it for you, and simplify that whole process.
Also, I wanted to do a little
work on figure.
Sorry, Daniel, go ahead.
Go ahead.
Yeah, I wanted to
really understand how our work and how and I guess we.
I think we are going to have to end a little bit early because the audio is acting up again. But I just wanted a couple things. Some of the questions that you submitted when you registered, we had some answers, and those are also on the slide deck that will be sent out. And then maybe a final comment from David, Daniel, and Brooks.
Yeah, one comment was that this is a cardiac webinar, so of course we want you submitting your tobacco and your cardiac measures as part of the project. And one of the nice things about those measures is that both of those measures are required in order to have a complete certified EHR. So those two measures are in all of your EHR systems. So those should be easy ones to submit. And then working on making sure that you're performing on those measures will also help you to align with the payment reimbursement going forward.
Okay, and we also have emails to all of the panelists in this slide. So if you have additional questions, you can follow up with them, but maybe first check with your state leads or your project leads, and then take a look at some of the answers submitted for these questions. Otherwise, our webinar will actually post us, but it will be posted through the Quinn QIO on January 21st, and it's about complex care and needs for patients with chronic conditions. And we will start up again with cardiac-specific webinars in February. So stay tuned and look out for your newsletter for the dates and topics on those. But otherwise, we thank you so much for being on this call. Again, we apologize for some of our technology issues. We will troubleshoot and make sure that this doesn't happen again. But any other questions, feel free to send them along. My email is included in the question or in the chat pane, so feel free to email me directly as well. But thank you again to our panelists for their expertise, their knowledge, and taking the time to share with us and prepare today. And thank you, everyone. Have a great rest of your day.